The subcommittee will come to order. The chair recognizes himself for an opening statement. Today we're marking up three bills. H.R. 2405, the Pandemic and All Hazards Preparedness Reauthorization Act of 2011. H.R. 1254, the Synthetic Drug Control Act of 2011. And H.R. 1852, the Children's Hospital Graduate Medical Education CHGME Support Reauthorization Act of 2011. For the sake of time, I will focus my remarks on H.R. 1852, a bill that I and Ranking Member Pallone have worked on to see that the Children's Hospital Graduate Medical Education program does not expire on September 30th of this year. The CHGME program has been tremendously successful since first being authorized in 1999. It trains 40% of our nation's pediatricians and 43% of pediatric subspecialists. More than 5,000 residents take part in this program every year, and 56 freestanding children's hospitals in the U.S. participate. In the 1990s, we saw a 13% decline in the number of pediatric residents. However, since 1999, when the CHGME program was enacted, the number of pediatric residents has increased 35%. During the program's lifetime, $2 billion has gone to train the next generation of pediatrician and pediatric subspecialists. Despite its success, President Obama zeroed out the CHGME program in his FY 2012 budget. Secretary Sebelius told this subcommittee that while she regretted eliminating CHGME funding, the department had to prioritize where scarce resources would go. I agree. In a fiscal situation like the one we find ourselves in, priorities have to be set and difficult decisions have to be made. However, quite honestly, I'm not sure how a successful program like CHGME that trains 40% of our nation's pediatricians didn't make it onto the department's priority list. The program's current authorization expires September 30, 2011, and that is why I and Ranking Member Pallone introduced H.R. 1852 to reauthorize the program at the current level of $330 million over the next 5 years. This is a bill about the health and lives of this nation's children, and it is a fiscally responsible bill continuing the CHGME program at its current authorization. I would like to thank Ranking Member Pallone for his help and cooperation and for the work he has done on this important bill, and I would urge all of my colleagues to support H.R. 1852. Now, I have some time left. I will yield to any member seeking recognition on our side of the aisle. The Vice Chairman, Dr. Burgess, yield the remainder of my time.
Thank you, Mr. Chairman, and I appreciate us having the markup on these important bills. I am certainly grateful that the Children's Hospital GME Support Reauthorization Act of 2011 is before us today, legislation that's critically important to our nation's medical workforce. And in the decades since the program was first fully funded, it has indeed, as you've pointed out, proved to be a remarkable success. I also appreciate us moving H.R. 2405, the Pandemic All Hazards Preparedness Act of 2011, another time-sensitive piece of legislation. Certainly in the aftermath of an attack, natural disaster, or pandemic, we need to be assured that adequate countermeasures to meet our nation's medical needs will be available. This program has also proven itself effective and deserves to be reauthorized and strengthened as this bill does. Mr. Chairman, I appreciate the recognition. I'll yield back to you the balance of the time.
Mr. Chairman.
I yield to Dr. Gingrey.
Mr. Chairman, thank you very much. I just wanted to comment on how important this program is in regard to continuing medical education at the pediatric hospitals across the country, and I think the chairman indicated there's some 56 of those, and it's really shocking almost that the president zeroed that funding out in his budget that he presented to us, maybe just assuming that we'd put it back in, but in any regard, if we did not have that funding, hospitals like Children's Healthcare of Atlanta on the Emory campus, which is such a fabulous training center for primary care physicians, particularly pediatricians, would have no funding in which to teach these young doctors. So with that, I'll yield back.
Thanks, gentlemen. Now recognize my friend from New Jersey, Mr. Pallone, for his opening statement.
Thank you, Chairman Pitts. I'm very happy to be here today to consider 3 bipartisan bills with great potential public health impact. H.R. 2405, the Pandemic and All Hazards Preparedness Reauthorization Act, H.R. 1254, the Synthetic Drug Control Act, and of course our bill, Mr. Pitts, H.R. 1852, the Children's Hospital Graduate Medical Education Support Reauthorization Act, and each of these has my full support. The Pandemic and All Hazards Preparedness Reauthorization Act makes improvements to programs and activities first established in both the 2004 Project BioShield Act and the 2006 Pandemic and All Hazardous Preparedness Act, also known as PAPA. I'm glad the subcommittee has carried on the tradition of working together on these critical preparedness programs. Together they will help our nation be equipped to respond to bioterrorism threats and attacks. There's still some outstanding issues that have not been fully addressed, but the amendment in the nature of a substitute, which will be considered today, is a step in the right direction. I know our staffs have made great progress, even as recently as yesterday, and I'm confident that all these matters will be resolved in time to move to full committee and in a way that only improves PAPA. H.R. 1254 also enjoys strong bipartisan support in its aim to eliminate commercial availability of harmful synthetic narcotics. Under this proposal, hallucinogenic drugs would no longer be able to hide behind misleading aliases. Around the country, use of these substances has led to heinous behavior and loss of life, and I appreciate the efforts of this subcommittee to prevent this from continuing in the future. And lastly, I'm pleased we're one step further towards passage of H.R. 1852, the Children's Hospital GME Reauthorization Bill, which will ensure that we have well-trained cadre of pediatric professionals. In the 90s, CHGME single-handedly reversed the declines in pediatric training programs which threatened the stability of the workforce. At a time when we're still facing a shortage of pediatricians in New Jersey and across the country, we should not slow down funds for the pipeline of new specialists. So I'll close by saying what a relief this process has been. I want to thank you again, Mr. Chairman, and the members of the subcommittee for the cooperation with which we've worked on all 3 bills that we're considering today, and hope we can make more of a habit of that. Thank you. Oh, yeah, I'll yield to the chairman. I'm sorry, to our ranking member of the full committee.
I thank you for yielding to me. I want to take the rest of your time rather than my own time to speak in favor of the 3 bills that are before us. They're 3 public health bills. We have a consensus in the committee. We'll have a bipartisan majority. In fact, a bipartisan consensus behind these bills. That's a worthwhile thing to have accomplished, and I thank the chairman and the ranking member of the subcommittee for their successful work. The Pandemic All Hazards Preparedness Reauthorization Act will be critical in helping to ensure our nation is well prepared to successfully manage the effects of natural disasters, infectious diseases, and acts of bioterrorism. The Synthetic Drug Control Act adds provisions, and it will enable the Drug Enforcement Agency to take appropriate actions to enforce the prohibition against these synthetic versions of abusive drugs, get them off the street and away from our young people. And finally, the Children's Hospital Graduate Medical Education Support Reauthorization Act provides ongoing and consistent financial support to hospitals for the training of doctors who want to specialize in pediatrics. Indeed, today, children's hospitals supported by this program train 40% of all pediatricians, 43% of all pediatric specialists. As Mr. Pallone has indicated, there's work to do on a number of the issues in the PAPA bill before it goes to full committee, but I feel confident we'll be able to work these matters out. I want to congratulate everybody involved and the consensus behind these important bills, and I look forward to supporting them. Yield back.
Chair, thanks, gentlemen. Now recognizes the chairman of the full committee, Mr. Upton, for 5 minutes for opening statement.
Well, thank you, Mr. Chairman, for holding this markup on the bipartisan Children's Hospital Graduate Medical Education, Bioterrorism, and Controlled Substance legislation. First passed in '99, this legislation provides support to children's hospitals for their pediatric medical residency programs. And today, 40% of pediatricians and pediatric specialists are trained with this funding. Even Secretary Sebelius couldn't explain the Obama administration's decision to eliminate this funding in their 12 budget, and this morning's markup is a bipartisan effort to ensure continued support for this very, very important program. Last week, we held a legislative hearing on Congressman Rogers' H.R. 2405, the Pandemic and All Hazards Preparedness Reauthorization Act of 2011, and Congressman Dent's bill, H.R. 1254, the Synthetic Drug Control Act. Congressman Rogers' bill would reauthorize certain provisions of the Project BioShield Act of 04 and Pandemic and All Hazards Preparedness Act of 06, so that we can continue to build the nation's preparedness infrastructure and foster the development of medical countermeasures to better respond to terrorist attacks. Congressman Dent's bill would make synthetic drugs that imitate the effects of drugs like marijuana, cocaine, and meth illegal so that we can prevent them from causing further harm to our nation's families. I want to particularly thank Mr. Waxman and Mr. Pallone for working with us on these bills. I would urge my colleagues to support all three bipartisan bills before the subcommittee today so that we can get to full committee and get them to the floor. And I yield back my time.
The chair reminds members that pursuant to committee rules, all members' opening statements will be made part of the record. Are there further opening statements? The chair recognizes Dr. Gangry for 1 minute.
Mr. Chairman, Project BioShield and the Pandemic and All Hazards Preparedness Act are two laws that exist to ensure that the United States is able to protect itself from foreign and terrorist threats. As we have heard in this committee, those threats can be as simple as drug-resistant bacteria for which no medicinal treatment exists. Terrorists armed with a biologic agent, like one of these superbugs, could threaten the lives of millions of Americans because we just simply do not have the antibiotics to fight them. Mr. Chairman, it's with these thoughts in mind that I look forward to supporting the reauthorization of H.R. 2405 and supporting the other two bills as well. And I thank the committee for its work, and I'll yield back.
Chair, thanks, gentlemen. Are there any other opening statements? If not, we'll proceed to the markup, and Chair calls up H.R. 2405 and asks the clerk to report.
H.R. 2405 to reauthorize certain provisions of the Public Health Service Act and the Federal
Without
Food
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Chair recognizes Representative Rogers for the purpose of offering an amendment in the nature of a substitute.
Yes, Mr. Chairman, I have an amendment at the desk.
Clerk will report the amendment.
An amendment offered by Mr. Rogers of Michigan.
Without objection, the reading of the amendment is dispensed with. The gentleman from Michigan is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman, for holding this markup. I also want to thank Chairman Upton for his help and assistance in getting us this far in this bill. And I'd just like to speak briefly, if I can, about some of the goals of H.R. 2405. The bill would reauthorize the Pandemic All Hazards Preparedness Act, reauthorizes BARDA and Project BioShield for 5 years. Both of these programs have been a tremendous success and are vital to the expanding medical countermeasure development. It reauthorizes several preparedness programs at HHS, including grant programs at CDC, which assist states, health departments, and hospitals to prepare for emergencies. The bill strengthens and strengthens the Assistant Secretary of Preparedness and Response. One of the issues we've determined is that she needs to have that extra authority in order to ensure that we have one person in charge of preparedness and planning at the department. Finally, the bill accelerates FDA review of medical countermeasures for national security priorities. This is incredibly important. The FDA will be required to interact with the countermeasure developers earlier and more often in order to ensure these critical products move through the review process. Importantly, the bill does not create any new programs or increase spending. All programs in the bill are reauthorized for 5 years at the fiscal 2011 appropriated level. The bill is consistent with the House's cut-go rules and represents a fiscally responsible approach to preparing our nation against the pandemic. or bioterrorism attack. Today's amendment in the nature of the substitute reflects the progress we've made with the minority and HHS to improve the bill, and I'd like to highlight a few changes included. It addresses many technical changes requested by the minority and HHS, including providing increased flexibility for FDA to meet new requirements in the bill. It includes a 5-year reauthorization of the emergency system for advanced registration of health professionals and volunteers. This program assists states in registering health professionals who can volunteer during disasters. The amendment also includes a 5-year reauthorization of the Volunteer Medical Reserve Corps, which helps train health professionals on preparedness. Finally, I know we are working on several other issues to address further concerns raised by the minority and HHS. And most importantly, we are working to overhaul the regulatory management plan to ensure it includes the flexibility needed for the FDA, while still providing an opportunity for early interaction between FDA and countermeasure sponsors, which I think is critical if we're going to move forward and be prepared for what we hope never happens, a biological attack or radiological in that sense as well. I'd like to thank Mr. Waxman and Mr. Pallone and their staffs for continuing to work with us on this bill, which has traditionally been a bipartisan effort. Thank you, Mr. Chairman. Look forward to the passage of the bill, and I yield back my time.
Chair thanks the gentleman. Is there any discussion of the substitute amendment?
Mr. Chairman.
Chair recognizes Ms. Baldwin.
Mr. Chairman, I move to strike the last word.
Gentlelady's recognized for 5 minutes.
Thank you. And I want to commend you, Mr. Chairman, for holding today's markup on several bipartisan measures. This markup demonstrates how productive we can be when we work together. One important issue that we will consider today is our nation's public health preparedness. We have certainly made great strides in improving our medical preparedness and response capabilities since Congress last authorized the Pandemic All Hazards Preparedness Act in 2006. However, I think many would agree that more can be done to enhance this measure, particularly when it comes to ensuring that our medical response systems are prepared to care for the critically ill and injured in the aftermath of a public health emergency. As you can imagine, when we face a health emergency such as a flu pandemic, the critical care delivery system is an integral component of our nation's medical response. Yet critical care medicine has been largely under-contemplated in our national health policy. Earlier this year, I introduced the Bipartisan Critical Care Assessment Act, H.R. 971, with my colleague from Minnesota, Eric Paulson. This measure seeks to identify gaps in the current critical care delivery model and bolster our capabilities to meet future demands. And relevant to today's markup, our bill would also improve federal disaster preparedness efforts to care for critically ill and injured. I have shared the relevant provisions of this bill with my colleagues, and I'm hopeful that I can work with members on both sides of the aisle to incorporate these important provisions into the Pandemic and All Hazards Preparedness reauthorization before we go to full committee markup. One important improvement that I hope to incorporate in this bill is to add critical care to the priorities within the nation's medical preparedness goals. While the legislation currently prioritizes increasing the preparedness, response capabilities, and surge capacities of hospitals and other healthcare facilities, including mental health facilities, trauma care, and emergency medical services systems, the measure before us does not currently prioritize critical care with respect to public health emergencies. Mr. Chairman, I believe that this is a shortcoming that we can address. When a natural disaster strikes or a pandemic sweeps the nation, the demand on critical care increases exponentially, and I hope we can work together to include critical care in this underlying bill. Another key improvement relates to medical surge capacity for public health emergencies. While we currently have federal databases to address surge capacity, it is important to ensure that the systems we have in place will work effectively and efficiently during an emergency. For this reason, I hope that we can work to include language to provide for periodic evaluation and testing of the databases to ensure, intended to ensure medical surge capacity. The importance of having a system in place for the effective deployment of needed medical personnel and supplies really cannot be underestimated. For example, during Hurricane Katrina, a physician who participates in the critical care roundtable and is employed by the federal government volunteered to provide medical assistance. However, this doctor spent the majority of his time sitting in a holding facility. And he wasn't alone. He was joined by over 80 other healthcare practitioners who also received only sporadic and uncoordinated assignments to provide medical care. The system failed to identify where this physician's services could be utilized despite the desperate need for such abilities and skills. Additionally, the 2009 H1N1 pandemic also illuminated the inefficiencies in the nation's preparedness in critical care infrastructure. During this time, hospitals and government officials scrambled to identify available ventilators for the critically ill, despite having databases in place. These examples illustrate the desperate need to periodically evaluate the federal databases to ensure that our nation is prepared to meet any needs during a public health emergency. I hope to continue to work with my colleagues to incorporate these important provisions into the reauthorizing legislation before we mark this bill up in full committee. I thank the chairman and my colleagues for continuing to work with me on these issues and yield back the remainder of my time.
Chair, thanks. The gentlelady. Is there any further discussion of the substitute amendment? Are there any bipartisan amendments to the amendment? Are there any other amendments? If there are no amendments, the vote occurs on the amendment in the nature of a substitute. All those in favor shall signify by saying aye. 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 All those opposed, no. The ayes have it, and the amendment is agreed to. You mean to report it to the full? All right, the question now occurs on favorably reporting the bill to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is favorably reported to the full committee. All right, the chair calls up H.R. 1254 and asks the clerk to report.
H.R. 1254 to amend the
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. The chair recognizes himself for the purpose of offering an amendment in the nature of a substitute. The clerk will report the amendment.
An amendment offered by Mr. Pitts of Pennsylvania.
Without objection, the reading of the amendment is dispensed with, and I recognize myself for 5 minutes in support of the amendment. As part of the subcommittee's hearing last week, we heard testimony from my good friend Congressman Charlie Dent on H.R. 1254, the Synthetic Drug Control Act. As Congressman Dent explained in his testimony, synthetic drugs imitate the effects of drugs like marijuana, cocaine, and methamphetamines. These drugs are just as dangerous, just as addictive, and just as deadly as the drugs they mimic. The amendment would add 4 additional compounds to be listed as controlled substances. These were identified after H.R. 1254 was introduced and further demonstrate how many of these synthetic drugs are being developed, all with the intention of circumventing our laws regarding dangerous illicit drugs. H.R. 1254 will provide the drug enforcement agencies the tools to address this growing threat. I yield back the balance of my time. Is there discussion of the substitute amendment? Are there any bipartisan amendments to the amendment? Are there any other amendments to the amendment? If there are no amendments, the vote occurs on the amendment in the nature of a substitute. All those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the amendment is agreed to. The question now occurs on favorably reporting the bill to the full committee. All those in favor say aye. Aye. Opposed, no. The ayes appear to have it. The ayes have it, and the bill is favorably reported. The chair calls up H.R. 1852 and asks the clerk to report.
H.R. 1852.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. The chair recognizes himself for 5 minutes. Children's hospitals are an essential component to our healthcare delivery system. The Children's Hospital Graduate Medical Education Payment Program is designed to help children's teaching hospitals, which do not receive significant federal support for their resident and intern training programs through Medicare. Since the program was first passed in 1999, the number of pediatricians in this country has steadily increased. The program has always received bipartisan support, and I am proud that H.R. 1852 now has over 100 bipartisan co-sponsors. I would like to thank Dr. Burgess and Ms. Capps for being original co-sponsors, and in particular, I would like to thank Ranking Member Mr. Pallone for all his work on this legislation. By reauthorizing this important program, we are able to help ensure that the mission of these teaching hospitals is continued. 5 years ago, when reauthorizing this program, the committee included accountability measures which required participating hospitals to report important data measures to the Department of Health and Human Services. H.R. 1852 continues these important reporting requirements and moves the report ahead by 1 year to facilitate legislative review. I urge my colleagues to support the legislation, and I yield back. Is there other discussion on the amendment? Mr. Engel of New York is recognized for 5 minutes.
Thank you very much, Mr. Chairman. I want to say, like many of my colleagues on the committee, I was shocked when I learned that the President had zeroed out the Children's Hospital Graduate Medical Education Program in his FY12 budget. This is a very important program. It has strong support on both sides of the aisle. It's essential for the training of future pediatricians and helps preserve health services for children, especially those who are underserved and in need of special medical attention. I've seen firsthand the benefits of this program and the good work being done at Blythedale Hospital in Westchester County, New York, and believe they render a great service to us all. I'm proud to be a co-sponsor of the Children's Hospital GME Support Reauthorization Act of 2011, and I'm pleased that we're considering it at today's markup. I want to, however, talk about a potential amendment that I'm strongly considering putting forth when we meet in full committee. And Mr. Chairman, I know that you have similar concerns about a hospital in your district, and I would like to, as we move closer to passage in the full committee, I'd like to work with you on that. For decades, we've known that people suffering from mental illness die sooner, on the average of 25 years sooner, and have higher rates of disability than the general population. In many instances, these diseases and conditions begin to appear in childhood and adolescence, when there is the greatest potential for intervention but are left unaddressed by doctors who cannot recognize the signs and symptoms and appropriate treatment options. Residency programs at children's psychiatric hospitals give providers the opportunity to learn from experts in the field about how to identify a child who may be calling out for help and begin to properly treat the child. So I believe that we should include certain children's psychiatric hospitals in the definition of children's hospitals eligible for funds through the Children's Hospital Graduate Medical Education Program. Only children's psychiatric hospitals that meet the current definition of a children's hospital used in the CHGME program would qualify for funding. These institutions have a Medicare provider number, treat almost exclusively children under age 18, and operate an approved medical residency training program. Like other children's hospitals, children's psychiatric hospitals cannot receive GME funding through Medicare because of their unique patient mix. Children's psychiatric hospitals, however, also cannot receive CHGME funding to support their residency programs because they are licensed as psychiatric hospitals, not children's hospitals, despite almost exclusively treating children. This amendment that I am considering not offering today but offering when we meet in full committee is supported by the American Academy of Child and Adolescent Psychiatry, the American Psychiatric Association, the National Alliance on Mental Health, the National Association for Children's Behavioral Health, the National Association of Psychiatric Health Systems, and the Association for Behavioral Health and Wellness. Only 0.5% of the total CHGME funds would be used to support residency programs in children's psychiatric hospitals. And under the White House amendment in the Senate, only 4 children's psychiatric hospitals currently meet the definition of an eligible hospital and train approximately 30 FTE residents total every year. More healthcare providers are needed to help recognize the first signs and symptoms of a child in need of help. According to the National Alliance on Mental Illness, 13% of children aged 8 to 15 have at least one mental disorder. In order to address this need, the U.S. Bureau of Health Professions believes 12,624 child and adolescent psychiatrists, double the current amount of providers, will be needed by 2020. Inpatient children's psychiatric hospitals tailor care and treatment to children with serious mental and behavioral health conditions, enabling residents to learn about the most effective treatment options for children with mental and behavioral health conditions has improved care for children across the country. For example, a pediatric psychiatrist who was trained in Rhode Island at an inpatient children's psychiatry hospital is in the process of establishing a program for severely autistic children in Pennsylvania to receive care. So I'm just mentioning all this, Mr. Chairman, because I think that there needs to be some changes. And again, I have an amendment, which I'm not offering today, that would do so. I know that you have an amendment. I'd like to have further discussion with you about this very important subject, and I yield back.
Chair thanks the gentleman. Are there any amendments to the bill? If not, the question now occurs on favorably reporting the bill to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is favorably reported. Without objection, staff is authorized to make technical and conforming changes to the bills approved by the subcommittee today. So ordered. I think that concludes the business committee. The subcommittee stands adjourned.